Hello everyone, this is Dr. Farzana Afzal, Assistant Professor, Isfahan Islamia Eye Institute and Hospital. Today we are talking about the evaluation of proptosis. So let's start. The definition proptosis is used in cases of the prominence of the eyeball due to various causes. But the exophthalmos is specific for secondary prominence of the eyeball secondary to the dysthyroid orbitopathy. When we call it proptosis, if the protrusion of eyeball is more than 21 millimeter, it again varies in various races. In cases of the Caucasian, if the measurement is more than 24 millimeter, then we call proptosis. Again, another form is asymmetry between the two eyes more than or equal to 2 millimeter is if present, then we call it proptosis. Pseudoproptosis, it is a term which we use in the cases where there is no proptosis but the eye appears to have proptosis. There may be various causes like ipsilateral lid retraction, contralateral ptosis, high myopia, contralateral enophthalmos or the microphthalmos, shallow orbit in cases of the craniosynostosis. We can classify the proptosis in different ways according to the etiology, laterality, direction of the globe displacement, time of onset, duration and course. According to the etiology, we can classify it congenital, especially in which is common in teratoma, inflammatory or infectious, which may be present in the orbital cellulitis or IOID, tumors, benign or malignant. This is IOID, tumors like benign or malignant cases. According to the laterality, it may be unilateral like dermoid cyst or hemangioma and IOID, lacrimal gland tumor, and bilateral in thyroid eye disease, lymphoma or the systemic metastasis. According to the direction of the globe displacement, we can classify it as axial proptosis, where the lesion is usually in the intracorneal space like optic nerve glioma, thyroid eye disease, cavernous hemangioma. And abaxial or non-axial proptosis, where the lesion is in extracorneal space like inferior-nasal dystopia caused by the superiotemporal growth, inferior-temporal dystopia caused by the superior-nasal growth like dermoid mucocele. Superolateral dystopia may be present due to the inferior-medial growth like lacrimal sac growth or the nasopharyngeal tumor, and the superior dystopia due to the inferior growth like maxillary sinus growth. Here we can see the lacrimal gland tumor causing inferior-medial dystopia and the here frontoethmoidal mucocele causing the inferior-lateral displacement. According to the age of onset, different causes of the proptosis are common in different age. Like in newborn, orbital cellulitis, neuroblastoma are common. In children, dermoid, hemangioma, optic nerve glioma. In young adult, thyroid eye disease, pseudotumor, mucocele meningioma may be common. In middle age, pseudotumor, thyroid eye disease, lacrimal gland tumor may be common. Meningioma may also be present. In senile patients, malignant and the metastatic tumors are the important cause. Duration. There it may be sudden onset, subacute or gradual onset. Sudden onset proptosis may be due to the retropulpar hemorrhage in cases of the trauma or orbital cellulitis, malignant tumor. Subacute may be due to the lymphangioma, idiopathic orbital inflammatory disease. Gradual onset may be due to the optic nerve glioma, capillary hemangioma, schwannoma, cavernous hemangioma, lacrimal gland tumor. Course or progression. It may be stationary like in dermoid cyst, gradually increasing like in thyroid eye disease, pseudotumor, cavernous hemangioma. Rapid progression like infection, inflammation, malignant transformation. Now evaluation. We can evaluate the tumor by taking the history, having the ocular examination and systemic examination, then investigation. At first, the ocular history. whether the tumor or the proptosis is sudden or gradual, whether the progression is stationary, acute or chronic, whether there is associated symptom like pain, diplopia, reduction of vision. Pain may be present due to the infection, inflammation, perineural spread of the tumor like lacrimal gland carcinoma. Diplopia may be present due to the muscle involvement or nerve supplying the muscle involvement. Vision reduction may be due to the optic nerve involvement or compression of the optic nerve, choroidal fold, macular edema, etc. We must take the history from medical. We take the medical history from the patient, like whether the patient have thyroid disease, whether the patient have hyper or hypo or euthyroid case. We should take the history of the diabetes, tuberculosis, sarcoidosis. These two diseases may cause the bilateral lacrimal gland enlargement. Neurofibromatosis, it may cause the optic nerve glioma or infiltration of the neurofibromatous tissue in the orbit or the absence of the sphenoid tissue and resulting in the transmission of the CSF pulsation. Also, we will take the history from the systemic cancer, which may causes the metastasis. In cases of the female, breast carcinoma is common to have the metastasis in the orbit, and in cases of the male, lung carcinoma is common. We must take the history from the family. If the patient family have the thyroid eye disease or neurofibromatosis, if there is any hereditary cancer history like breast carcinoma, any systemic familial disease present or not. Now the examination. At first, we should inspect the patient carefully. There may be any facial asymmetry due to the neurofibromatosis, any globe displacement, and the direction of the globe displacement must be examined. Any pulsating proptosis are present or not, which may be common in the vascular tumor or neurofibromatosis keratoconus fistula cases. Any positional proptosis is present or not, which we can examine by the Valsalva maneuver. It is common in the orbital varices. The color of the eye surrounding in the proptosis eye, it is red in hemangioma, blue in varices or lymphangioma, and the periorbital area must be checked whether in erythema or the any edema. We can check the proptosis by Navziger sign and the Worm's eye view. Navziger sign is examined by performed by the patient seated head up looking downward and the examiner standing behind and slightly above the patient looking over the forehead and assess whether the cornea protrudes beyond the superior orbital rim. The examiner compares the position of the cornea of both eyes to determine if there is any asymmetry or protrusion. Worm's eye view. Examining the proptosis by positioning the patient with their head tilted and backwards, allowing the examiner to view the eyes from below. Eyelid. We must check the eyelid signs like lid retraction or the lid lag, which are common in thyroid eye disease. And in some patients, along with the lid retraction, patient may have the contralateral ptosis, which are common in 10 to 15% cases of the thyroid eye disease because of the associated myasthenia gravis. Also, the patient may have the eyelid edema and eyelid ecchymosis, especially in cases of the trauma. In conjunctiva, we will check the localized edema, salmon patches, which is common in the orbital and the conjunctival lymphoma, episcleral vessels present in the keratoconus fistula. We must check the pupil. RAPD is present, which indicate if present, it indicates the compression or involvement of the optic nerve. We must check the ocular motility. If patient complains of any diplopia or patient may have ophthalmoplegia. We will check the slit lamp examination must be done. We will check the cornea for exposure keratitis, iris. There may be iris leash nodules common in the neurofibromatosis, and also we will see the anterior chamber lens, etc. Fundus must be examined to see a choroidal fold, optic disc edema, optic atrophy, macular edema. Nasopharynx and oral cavity must be checked to if we suspect sinus disease or intranasal sources of proptosis or intraoral sources. Here we can see the sinus disease is involving the orbit also. Then the palpation. We must check the temperature and the tenderness. Retropulsion, which we can examine by gently press the globe with thumb to finger palm over the closed eyelid to know whether it can be pushed back in the orbit. It may be compressible, which are common in the highly vascular tumor, and non-compressible in solid tumor like optic nerve glioma. Reducibility is checked by pushing the globe with fingers to observe whether it can be pushed back in the orbit and if it returns back to its original position when released. Reducible in vascular tumor, non-reducible in lacrimal gland tumor, thyroid eye disease, pseudotumor. Thrill. It is examined by placing the index and the middle finger on closed eyelid and feel the pulsation. It is we can feel the pulsation in caroticocavernous fistula, highly vascular tumor. We will palpate the orbital rim with index finger to feel any mass, any erosion or irregularities. Palpation of the anterior orbital mass is important if there is any mass present in the anterior orbit. So we must check the size, shape, consistency, attachment with the skin or underlying structure, tenderness, posterior margin, overlying skin changes. Then we will check the regional lymph node, the preauricular, submandibular and the anterior cervical chain. Supraorbital and the infraorbital anesthesia may be common. We will check for pain, numbness and paresthesia. Pain is common due to the perineural infiltration in adenocystic carcinoma of the lacrimal gland. Auscultation. Bruit as examined with the bell of stethoscope, we can find the gushing sound in caroticocavernous fistula. Now the pre-measurement of the proptosis. One is ruler method. Here the patient looks straight ahead. The examiner places the ruler on the lateral orbital margin. The distance from the lateral orbital rim to the apex of the cornea is measured. The measurement is typically taken in millimeters. There are various types of measurement tool. Those are called the Hartel's exophthalmometer, Lued's exophthalmometer, Nagel exophthalmometer. In Hartel exophthalmometer, the patient and examiner must be seated at the same level, and then we locate the orbital notch near the lateral canthus, adjust the foot plate to fit the orbital on the orbital rim. Baseline reading is taken. Patient is then asked to look straight forward, and we will look into the exophthalmometer. Red line should be overlapped to avoid the parallax. Then we will look through the mirror within the exophthalmometer. Note the millimeter mark corresponding to the corneal apex position on the scale. Here we can see the marking in the corneal apex. Normal range is 12 to 20 millimeter, but this can vary slightly based on the ethnicity and the age. Asymmetry, more than 2 millimeter difference between the two eyes is generally considered abnormal. How we can measure the dystopia or non-axial proptosis? By the two-ruler method, specifically used in assessing the vertical orbital dystopia, involve measuring the vertical displacement of the eyes using two rulers. One ruler is placed horizontally, centered on the nose and passing through the outer corners of the eye, and the other ruler is then used to measure the vertical distance from this plane to corneal reflex of the each eye. The difference in these measurements indicates the degree of vertical dystopia. We also can measure the horizontal dystopia by this horizontal placement of the ruler. The other examinations are the transillumination tests, which are present in positive in the cystic lesions. Visual acuity must be checked. Tonometry, that means IOP, must be examined also in various gazes. For force junction test for the myopathy, diplopia chart if any ophthalmoplegia, Color vision are earliest, it is the earliest sign of the optic nerve involvement, and visual field evaluation in the bedside we can examine it by the confrontation test. Systemic examination, neck gland examination, especially the thyroid gland must be examined. Any mark in the skin like cafe olive spot which may be common in the neurofibromatosis. Hand must be checked for sweating, radial pulse, thyroid acropathy and fine tremor. This must be checked if we suspect the patient have thyroid eye disease. Lower extremity for the pretibial myxedema, again common in the again may be present in the thyroid eye disease. Now the investigation. We can give the patient serum T3, T4, TSH, CBC, ESR, angiotensin converting enzyme for sarcoidosis, CANCA for sarcoidosis, quantiferon TB gold test. Imaging have a very important role in cases of the proptosis. We can go for the plain X-ray, CT scan, MRI, orbital ultrasonography. Orbital ultrasonography is a non-radiational, non-invasive, completely safe and valuable initial scanning for the orbital lesions. Indications are the proptosis and the globe displacement, any ocular pain, raise in the IOP, optic disc edema, atrophy, vascular retinal occlusion, choroidal fold, orbital trauma. Plain X-ray indications are the enlargement of the orbit, enlargement of the sphenoidal fissure, enlargement of the optic foramen, bony destruction, calcification, soft tissue changes. CT scan of the orbit. It is the gold standard investigation. Three-dimensional visualization are found. Coronal view, axial view and the sagittal view gives us a good point for examining the proptosis. Visualize the globe, extraocular muscle, optic nerve, orbital wall, cranial cavity, paranasal sinus and the nasal cavity. Lesions appear as an abnormal density. Now we will see some CT scan film to diagnose the different type of disease which causes the proptosis. Here it is a CT scan of the orbit in thyroid associated orbitopathy. In cornea section we can see all the rectus muscle are enlarged. In sagittal, this is the axial section. Here we can see the muscle belly are enlarged, but it is sparing the tendon. We can call it the Coca-Cola shaped. This is a thyroid associated orbitopathy. The idiopathic orbital inflammatory disease, same the muscles are enlarged here, but here we can see the tendon is also involved. It is the this is the dacryoadenitis, the enlargement of the lacrimal gland. In orbital cellulitis cases, we can see the soft tissue inflammation around the orbit. Optic nerve glioma, we can see the fusiform enlargement of the optic nerve in sagittal view, also in the axial view. This is the axial section, where we can see the optic nerve surrounded by the meninges, hyperdense meninges. This is a railway or tram track appearance in optic nerve sheath meningioma. Cavernous hemangioma, well defined and hyperdense lesion within the cone of the orbit, retrobulbar. Lymphangioma, here we can see the cystic lesions in the orbit. Orbital lymphoma, soft tissue lesions, especially it is molding around the orbit rather than it is pushing forward. It is molding around the orbit. Lacrimal gland tumor, here this is the benign tumor, pleomorphic adenoma. Maybe there is hyperstosis, but no bony remodeling may be there, but no bony destruction. On the other hand, this lacrimal gland tumor causing the bony destruction. So this is adenocystic carcinoma of the lacrimal gland. Orbital metastasis, here we can see multiple intracranial tumor, and this is also invading the orbit, pushing the orbit forward. So these are some CT scan film. Hope this lecture will help you to understand proptosis and evaluation. Thank you all.